are the slides for professionals, but I will try and talk this through in a way that's understandable to all that are at the conference and all that are remote. This is an update from the previous National Institutes of Health criteria that were published over 30 years ago, and also an update from myself in Manchester, which are nearly 30 years old. So it was time that these criteria were updated. So you can see on this slide, the contribution, you can see there's a lot of contribution from Europe. And in fact, 4 of the 6 main individuals who drove the criteria were from Europe, including 2 from the UK. You can see here the others. Scott Plotkin really was hugely important in driving forward this initiative, and this was initiative was funded by the CTF in the United States. So these are the professionals that took part. You can see that we have representation from clinical epidemiology, clinical genetics, dermatology, genetic counseling, internal medicine scientists, molecular geneticists, neurology, neuro-oncology, neurosurgery, ophthalmology, pathology, pediatrics, etc. So huge representation. We went through a process called a Delphi process, where we develop recommendations, and those are then scored by individuals as either highly acceptable or not acceptable, etc. And so we need to reach consensus, and we went over at least 3 rounds of Delphi to get consensus for this. So this was a very, very interactive process, and involved a number of in-person meetings, including in New York and in Paris. So the rationale for changing the criteria are that there had been no updates for NF1 since the original criteria was established in 1987. The current criteria were established prior to the recognition of schwannomatosis as distinct from NF2, the discovery of all of the genes, NF1, NF2, and the schwannomatosis genes, before the ability to perform genetic testing, and before new clinical information about both NF1, NF2, and schwannomatosis, and also to clarify the historical confusion between NF1 and NF2, which should never have been put under the same umbrella. So the guiding principles were that these should accurately and clearly delineate the conditions, represent the best consensus among NF experts, reflect input from patients, families, and foundations. And there was a process where these were discussed at a number of webinars with representatives from NF Europe and from the United States. Be broadly representative of medical specialties and national groups, usable by general doctors as well as NF specialists. And now these are diagnostic criteria for experts, not so necessarily that patients can diagnose themselves, although obviously they can be used that way. Recognize advances in genetics over 30 years and be acceptable in different countries and healthcare systems. So you can see here the development here, the Delphi process with an in-person meeting in New York, another in-person meeting in Paris, and then an international meeting in San Francisco, and the rounds of Delphi. So this has taken a considerable length of time, and we hope it's as good as we can get it. So one of the things to understand is that we now in genetics call the genetic changes in the genes as to whether they cause the disease, and that means pathogenic, so disease causing. Heterozygous means it's on one copy of the gene, and we know that all of the NF conditions and schwannomatosis are caused by having a faulty copy on one copy and a 50-50 chance of passing that on. And there has been a big sea change in how we classify genetic variants. And in order for them to be ratified as definitely causing disease, they get this term pathogenic heterozygous variant. And there has been huge amounts of work both on NF1, NF2, and the schwannomatoses gene LZTR1 and SMARTB1 to identify what are pathogenic variants and what are not. And there's actually another iterative process going on by a ClinGen group to ratify how we classify these variants. And the gold standard is this publication in Genetics in Medicine, the ACMG standard. So that's the American College of Medical Genetics Standards and Guidelines. So these are the original NIH diagnostic criteria. And I have to say for NF1, these have really stood the test of time. You can see here the 6 Caffiole macules. They need to be larger after puberty. And you can see here that this is a Caffiole macule, a Caffiole spot, and that you can see the edges of the spot are relatively straight. We do not tend to see raggedy edged Caffiole spots. And this does distinguish NF1 from a number of DNA repair disorders where you get raggedy Caffiole spots. What we call the coast of California, this rather straight-edged to the Caffiole spots, as opposed to the coast of Maine, which is really raggedy-edged. But 6 or more Caffiole macules is one of the diagnostic criteria, and probably the most important, because around 99% of children who have NF1 have developed 6 Caffiole spots by the age of 5 or 6. So it really is an important one. Then all you need to fulfill the diagnostic criteria is one of these other criteria. You can see here the freckling in the non-sun exposed areas here in the armpits. These are optic pathway gliomas. This is an osseous lesion, sphenoid wing dysplasia. So that's a bone at the back of the eye. You can see here, obviously, many of you will have these lumps, cutaneous neurofibromas, and Lisch nodules. And these make up the main criteria, but also we allowed an affected first-degree relative with NF1. So if your mother or father had NF1, all you would need to meet the criteria was to have 6 Caffiole macules, and then that would allow a diagnosis usually very early in life. So the main changes to the criteria, and they are very few, is some clarification of language. So 2 or more iris Lisch nodules identified by slit lamp examination, or 2 or more choroidal abnormalities. Now, these are abnormalities in the eye that can be identified by ophthalmologists. So they are specialist, only able to be done by specialist examination. We've added the word pathway to glioma, and we've also made some difference in language in how we talk about the bone. So anterior lateral bowing of the tibia, or pseudarthrosis of a long bone. So that has been sort of clarified. And then very importantly, we've added this heterozygous pathogenic NF1 variant in 100% of unaffected tissue. So that's in blood, or in a skin sample, or in a saliva sample. And then we have clarified that it needs to be a parent with NF1 rather than a sibling. And this is because we needed to establish that if you had a child, for instance, who had a number of Caffiole spots and freckling, and then another child was born with the same, we needed to establish a difference between recessive DNA repair disorders, such as congenital mismatch repair, and Fanconi syndrome, which can cause that. And what we didn't want to do was for two children to be diagnosed with NF1 when they actually had a different condition. So we now only allow parents here. And there is also a note back here, and there was a big discussion about this, that making the diagnosis with only pigmentary criteria in a child, such as 6 Café-LA patches and freckling, we need to know that that is not definitive. So although the vast majority, probably 90% plus of children who have those will have NF1 with no family history, there is overlap with some of these rarer conditions, but also specifically Leigh syndrome, where all you get really is the Café-LA marks. So this is the Leigh syndrome. You're allowed one less Café-LA spot and no other NF1 related diagnostic criteria apart from axillary or inguinal freckling. And then a heterozygous variant in the SPRED1 gene in an unaffected tissue. So you can only make this diagnosis with genetic testing for SPRED1. And obviously, if you have a parent with proven SPRED1 and you have the 5 Café-LA patches or you have the SPRED1 gene change, you're then diagnosed. But going back again to this, the importance here of this 7th criteria is that it now encourages genetic testing. So until recently, there really wasn't an incentive in many parts of the world to do genetic testing for NF1 because, oh, well, the diagnosis is obvious. You don't need to do it. Well, it's not always obvious. You know, many of you may have had a child born with NF1 and they have 6 Café-LA spots, but no freckling, no other features. And you want to know whether they have NF1. I've already said it's highly likely they do, but you want to know for certain. So if you do a genetic test on a blood sample and you find a pathogenic variant in NF1, they then meet the diagnostic criteria. So that's a really important addition, and it encourages genetic testing. And it also means that you would test the SPRED1 gene in that situation so that you can clarify the difference between NF1 and Leigh syndrome. Now, we also talk specifically about mosaicism in NF1. Now, we know that a significant proportion of people have a partial type of NF1, where the gene fault was not inherited in the egg or sperm that made them, and therefore in all of the cells, but only in some of the cells. So it, for instance, might be on a patch of their skin like this, as you can see on this person, but not on the rest of them, what is often called segmental NF1. And this is because the genetic changes occurred during development as an embryo and only affects certain parts of the body. Now, if it occurs early enough, maybe in perhaps 10% of the cells or 8% of the cells all around the body in every tissue type, and still give you the appearance of classical NF1, but it will be mosaic. So the likelihood of passing on NF1 will depend on the proportion of the cells in the egg cells or the sperm cells that that person has. So these are the diagnostic criteria for mosaic NF1. I'm not going to go into great detail, but just really to say it cannot be done really without doing genetic testing, except obviously someone with a clearly segmental distribution of the Café-LA spots and neurofibromas really is very likely to have that situation. And again, mosaic Leigh syndrome, relatively uncommon, can be again diagnosed by doing genetic testing. And what we can do now, and what will be presented hopefully at the conference if it gets back up to speed, is that we can do testing of Café-au-lait spots and test 2 or 3 different Café-au-lait spots on someone's skin. And if we find an identical fault in the NF1 gene between all those different Café-au-lait spots, that then confirms the NF1 condition. And in spread 1, you can do the same thing. So I know most of you probably will be from the NF1 side of things. So I'm not going to go into as much detail about NF2, even though the changes are bigger. These are the Manchester criteria that were published in 1992. And you can see here that bilateral, so on both sides, tumors called schwannomas on the vestibular nerve give you a diagnosis. And you can also get a diagnosis by having a first-degree relative and a unilateral tumor on the 8th cranial nerve, the balance nerve, or having 2 other features of NF2, or having multiple meningiomas and 2 other features of NF2. So schwannomatosis criteria in the past clinically were based on the absence of vestibular schwannomas and the absence of other critical NF2 features like cataracts and ependymomas, but the presence of multiple schwannomas. So it was a sort of diagnosis of exclusion. But we know that this is not good because many people who meet these schwannomatosis criteria actually have mosaic NF2. So mosaic NF2 can cause you to have multiple tumors on the nerves that are schwannomas without it affecting the vestibular nerve. And as part of this, we had to discuss the whole idea of a name change, that the reason that neurofibromatosis type 2 was ever called that is because of a very famous American neurosurgeon called Harvey Cushing, who in the early part of the last century said that people with von Recklinghausen neurofibromatosis, or NF1, could develop these tumors on the hearing and balance nerve. And because he was so famous and so powerful, it took 70 years to unpick that. And that is why NF2 is called neurofibromatosis, even though you do not get neurofibromas in NF2. So, the whole concept is wrong because neurofibromas aren't part of NF2. So we then discussed an umbrella term for the schwannomatosis condition. We went down the path of schwannoma predisposition syndrome, or SBS, and eventually we have settled for, we tried to get rid of the whole NF2 term, but the Human Genome Naming Committee would not allow that because it has been written in stone for so long, but they did get rid of the term neurofibromin 2 as the gene name. So what we have run with is the gene name and related schwannomatosis. So NF2 or Merlin-related schwannomatosis, SMARTB1 schwannomatosis, LZTR1 schwannomatosis, or 22q schwannomatosis, where we can't be sure that it's any of those, or we have excluded all of those genes. And it shows the typical pattern of genetic fault in the tumors associated with chromosome 22. So these, as I've said, but again, the importance is of genetic testing. So that is now enshrined in the criteria that we have specified, again, that these major criteria now, so 1 major criteria and 2 minor criteria, these are really just as before in the Manchester criteria, except we've added the pathogenic variants in an unaffected tissue. And then we've also made some clarifications here about the minor criteria. Juvenile subcapsular cataract, which is a type of cataract you get in NF2, retinal hamartoma, which is a congenital abnormality at the back of the eye, and an epiretinal membrane aged less than 40, and a meningioma can only count if you haven't already counted it as a major criterion. So a little bit more complex than the NF1, where you only require 2 criteria. You have to have a major criterion, but you can get it with 2 major criteria or 1 major and 2 minor criteria, or to have bilateral vestibular schwannomas. And then really, we're just going down the path where if you identify a patient with multiple schwannomas and they have a SMARCB1 genetic variant found in blood, effectively they are SMARCB1 related schwannomatosis. And this slide just shows you the typical pattern. There are 4 genetic hits in the tumor that you start with a SMARCB1 genetic fault, you then lose 1 copy of chromosome 22, and then you get the 3rd event, or the 4th hit, which is the NF2 genetic change. That is exactly the same as what happens in LZTR1. So again, you can't make the diagnosis without genetic testing. You get the same effect in the tumors, the 4 hits, 3 event hypothesis, and that confirms LZTR1 related schwannomatosis. And then 22q is exactly the same, that the tumors have faults in NF2 and a loss of the normal copy, but you can't identify a fault in LZTR1 or SMARCB1, and there is no common genetic change in NF2 between the tumors. So the NF2 changes are always different. And again, that's your molecular signature. So the recommended criteria for schwannomatosis not otherwise specified is when you haven't been able to make a diagnosis via the other routes. So clearly, genetic analysis is absolutely essential for the schwannomatosis conditions, although you can make a diagnosis clinically of NF2 without doing the genetic testing. The one situation where you really should be doing the testing where people meet NF2 criteria is if they have a unilateral tumor on the hearing and balance nerve, a unilateral vestibular schwannoma, and 2 or more other schwannomas, but no other NF2 related problems. And that is an overlap with the LZTR1 condition, because about 10% of people with LZTR1 related schwannomatosis develop a vestibular schwannoma. So vestibular schwannoma can no longer be an exclusion criteria for the diagnosis of other schwannomatoses. So I've just left enough time for some questions. We obviously have to acknowledge the amazing work of the Children's Tumor Foundation, especially Patrice Panzer, who really administratively drove the entire process. All of these have now been published in Genetics in Medicine, a very high impact genetics journal. And obviously many, many people who participated in the Delphi process and in the webinars. And we know that the name change may not be the NF2 related schwannomatosis, or NF2 Merlin schwannomatosis may not be liked by everyone, but really we felt as a community, and particularly as a medical and scientific community, that we really did need to write this now, and we have now published this. So we would really appreciate it if everyone could come on board and stop calling NF2 neurofibromatosis.